Hi, this is Brian Kim. I'm going to share with you case number 118, the best way to do cataract surgery series. This is a 2 to 3 plus dense lens. You're going to see efficient lens disassembly without the need to spin the lens within the bag. And so, with capsular fornix hydrodissection, I get a nice hydrodissection wave, but it doesn't always guarantee that the lens is going to spin efficiently within the bag, especially in the cases of weak zonules. That's what my experience has shown. And so you're going to be able to see how I'm able to disassemble this lens without needing to spin the lens at all within the bag. Again, in this situation, you would be completely disrupted and handcuffed if you're doing pure sculpting techniques with divide and conquer and things like that. And you'll be able to see how I'm able to efficiently disassemble this lens and remove the lens without having to spin the lens within the bag. So I'm using a cotton tip to steady the eye, and then using a corneal marker, which will help me to center incisor-rhexis. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf and allows a self-sealing incision. So this is intracameral lidocaine, and this is some intracameral epinephrine. And this is dispersive viscoelastic to fill the chamber and coating the corneal endothelium. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me using the cannula, and then I enter. I push some more viscoelastic. And this is the puncture style rhexis. I puncture the center of the capsule, pull towards me. I'm able to get a nice tear there. When I pull towards me, I pull a little bit to the right to create a little bit of a flap. Grab the right side of the tear to create that flap. Go around circumferentially, again, using the corneal mark that I made as a guide to help center incisor-rhexis. Decompress, and this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress on the left side, go ahead and spin the lens on the right side. And so in this case, you do see that the lens spins quite nicely. But just because it spins during hydrodissection doesn't mean it will spin easily with lens disassembly, and you'll see that here. Irrigate the surface of the eye. Lift the incision with the chopper going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Placing the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, fracturing the lens in half. Placing the chopper around the right heminucleus, crushing it against the phaco tip, and that is the cross-chop maneuver. Using some vacuum to lift that first quadrant up out of the bag, and then successively using crushing forces between the two instruments, and then emulsifying the lens piece. Placing the chopper around that second quadrant, trying to hook it and lift it, and then crushing the lens piece, and now it's gone. And so this is where I get stuck. The lens, that second heminucleus doesn't want to turn for whatever reason. And so let's see, I have several options. I can try to hydrodissect again. I can try to viscodissect the lens up. And so let's see what I do here. So first I hydrodissect some more. And then I'm using the cannula to control the lens piece. You can see I'm able to turn the cannula tip. You see that? I'm rotating it down and around. And as I do this, look at that, it pops the endonucleus up out of the bag. And so I'm able to use the hydrodissection cannula as a little bit of a hook to lift that piece up out of the bag. I push some more viscoelastic between the capsular bag and the lens piece, and then push some viscoelastic between the lens and the endothelium of the cornea. I'm able to now sandwich the lens completely in half. Crushing the lens into smaller and smaller pieces. Using the vacuum to grab that last quadrant and then getting around the lens, crushing it between the instruments. You can see this lens is quite dense. Crushing it between the instruments and then emulsifying the lens pieces. So again, because we had to use that technique to grab the lens, it's, the lens pieces are coming out kind of in a weird way. There's mixed with endonucleus, epinucleus, crushing it into smaller pieces. But the point is I'm able to very efficiently crush the lens pieces and emulsify the lens pieces because I was able to use that cannula to pop that lens up out of the bag. So now the endonucleus is removed. Go ahead and grab the anterior aspect of the epinucleus here, which starts to come out very slowly. Protecting the posterior capsule with the chopper. So yeah, the epinucleus clearly is a little bit more adherent to the capsular bag. You have to be very careful in this situation because if the epinucleus is attached to the capsular bag, if you're not careful, as you're aspirating the epinucleus, you might accidentally aspirate the posterior capsule. So because of that, I go ahead and switch, take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I start sub-incisionally peeling off the cortex, and as I do that, it released that piece of epinucleus, and now I'm able to remove the epinucleus more efficiently and safely here. Start to remove the cortical material now. And normally I notice that when you have an adherent epinucleus, you're more likely to have these fine cortical wisps. So I switch to polish mode, polishing underneath the rhexis edge. And I'm going to have more of that fine cortical material in this situation. It's just going to be a little bit more tedious. You're going to see I'm using the polish mode to my advantage to be very carefully tease out that stubborn cortical material. So I pulse the sub-incisional capsulorhexis with the BSS. And as you can see, there's a bunch of stuff there. Again, not unexpected in this context. Go ahead and fill the capsular bag with cohesive viscoelastic, and then I start to sweep under the rhexis edge, first on the left side, and then on the right side. Inject the single piece acrylic lens into the capsular bag, making sure the leading edge goes inside the bag. Go in with irrigation off, activate irrigation, making sure the haptics are off the optic, going underneath the lens, tilting it, rotating the lens 90 degrees clockwise, removing the viscoelastic from within the bag. Polishing under the rhexis edge. Rotating the lens, centering the lens, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So again, this case, you can see that I did hydrodissect well, and I got a nice spinning of the lens right afterward. But for whatever reason, once I disassembled and removed those first two quadrants, that second heminucleus, which was essentially sub-incisional, wouldn't budge. And I didn't want to push very aggressively against the zonule. So that's the thing. You'll see some people just kind of just ram the instruments and just try to apply significant torsional force on the capsular bag. You might be able to get away with it now, but then, 10 years or 20 years later, that patient's going to come in with a sublux IOL, and you're going to wonder, why did that happen? So I don't ever want to create a problem, and I want to be very gentle on the zonules. Anytime I'm having to apply any little bit of force on the zonules, I want to think to myself, what can I do besides that? And the easy thing is, in this case, my hydrodissection cannula was a game changer. It's a right angle cannula. It's blunt tipped. I was able to hydrodissect with it, loosen the endonucleus from the bag and the remainder of the lens material, and I basically hooked it. I basically rotated the tip of the cannula around 180 degrees downward, and it was able to just pop the lens up out of the bag, and then I was able to access that second heminucleus confidently, chopping it into smaller pieces, and the remainder of the case went well. And as a result, I feel like this is, again, the best way to do cataract surgery. I hope this was helpful to you, and I thank you for your attention.